Sounds good.
Welcome, everyone. Thank you for joining us today for another one of our Lunch and Learn sessions. I think some of you have been to others. This is a new program we started in September where we have a topic of current interest each month, and it's usually the last Tuesday at noontime. We're very happy today to have Michele Schuckel, am I saying your name right?
Yes, thanks.
With us here today. Michele is our public health nurse, and she's here to talk about the opioid crisis and what Wayland's response is. So I think this will be a very timely and important topic. So welcome, Michele.
Thanks. Hi, everybody. Thanks for coming out today and being with each other. Community is such an important thing, and I think we've lost that a little bit, right? We're getting our sea legs back again, and it's really nice to do that. Just a little bit about me. So I'm Michele Schuckel again. I'm your public health nurse. I've been here since September of 22. And I'm also the public health nurse in Weston, very part-time. Full-time here, very part-time there. Hi, Julia. We are really fortunate here in Wayland to have the resources to have somebody like me here full-time within the public health department. We do lots of different things. I don't know how often any of you sort of head down our way. We cover environmental health to human health for the entire spectrum of ages in Wayland. And I'm really grateful that the school health program also falls under our purview. So we get to work with a really great team of school nurses, which are typically employed by a school district. Instead, they work in the health department. And that really, I think, allows us to sort of stay on the cutting edge of the newest research-driven, data-driven health initiatives for our young people. So it's great. Just a little bit about me. I started my career in inpatient oncology. I did home hospice work and community work, moved into medical software, got a degree in business, did a lot of work in systems, which really informs like sort of my systems thinking, sort of involving politics and history and art and science, all in the sort of healthcare realm, which I think allows for a different kind of comprehensive thinking. And then during the pandemic, I actually fell in love with public health, the idea of giving people tools, empowering people with knowledge and information to make their lives better, and to be able to reach people through the public health sort of spectrum is really great. So I'm actually enrolled part-time at BU getting a master's in public health in health equity. So I love this. So if there's questions you have, certainly feel free to stop by, and obviously I'm happy to have one-on-one conversations about anything we talk about today. Our agenda is, hi.
Thank you.
Sure, of course. No. So our agenda is pretty robust today. Please feel free to stop me with questions, or I'm happy to take them at the end also. Really, I want to talk about the big picture of the opioid crisis. You've probably heard the term. I'll kind of give us a little level set in history and kind of what we're talking about here. We're going to talk about the Opioid Abatement Settlement Funds Initiative, which is something else you might have heard about, but some context will help us sort of understand that. And then we're going to move into sort of the personal aspects of opioids and talk about what harm reduction is, what addiction is, what an opioid overdose is, and how to respond. So I'm hopeful today to give you like big picture information all the way down to useful tools, and somewhere along the way, hopefully, pique your interest or meet your need in some way. So starting first, big picture, what are opioids? Opioids are painkillers. They're drugs that act on the nervous system to relieve pain. There's different kinds of painkillers. Opioids are just one type of those. They attach to and activate the opioid receptors in the brain to block pain, and as a result can boost pleasure. That's just sort of how the biology of that works. So this is just sort of like a cross-section of if we could look inside the brain and see what an opioid receptor looks like. This is just a visual for that. Opioids also act on the central nervous system, and they reduce our respiration. So they operate or act as respiratory depressants. So when you have too many opioids in your body, that can reduce your ability to breathe. So just sort of helpful big picture thinking about what they are. There are lots of types of opioids. I've divided them into 3 classes or groups just so we can sort of think about it a little bit. give some context. So natural opioids are derived from the opium poppy plant. So examples of this would be morphine and codeine. These are sometimes used in prescription painkillers like oxycodone or Percocet. And that's how you may have experienced or have come across these in your life at some point. And then there's semi-synthetic, so a combination of opioids that were created in a lab from natural opiates. Examples of this are heroin, oxycodone, hydrocodone. These are available in New England as street drugs, and what we're finding is, like, sort of, if we look at the DEA data, we can find that pill use can lead to heroin use. So we find some use of drugs on a continuum for some people. Synthetic opioids are completely man-made, and examples of this are methadone and fentanyl. Fentanyl is 80 to 100 times more potent than heroin. So as a synthetic opioid, it's extremely powerful, and the amount that it takes to sort of change one's brain function is very small in physical amount of a synthetic opioid. So I'm going to talk about this slide for a minute, and I think it sort of is helpful because it gives us some history. I know there's a lot of information on here, but I'm going to walk us through it. Essentially, the opioid epidemic in the United States happened in 3 waves. So across the bottom of our graph is a timeline starting in around 1999, and that's where wave 1 begins in the 1990s, with a rise in prescription opioid overdose deaths. So that carries through in the gray line. You see it sort of rises and sort of stays pretty steady throughout the course of the following 20 years. Wave 2 is marked in purple, and that's the rise in heroin overdose deaths, which started around 2010. And then wave 3 is a rise in synthetic opioid overdose deaths, and that started around 2013. So it's helpful to think about this because as we consider how do we respond to this, what we talk about very broadly as the opioid epidemic or the opioid crisis, it's not really one thing. It's sort of 3 parts that all kind of connect and relate to each other. Any one of these can be addressed with different science, different thinking, different history, different policy, different public response. But when we talk about the opioid crisis, we sort of all mix it all up together. So I try to kind of split it up a little bit because if you're trying to understand how as a society we're responding, it helps to kind of break it down into these waves. And that's actually why I preceded this with what are the different types of opioids, because those relate to the waves, if that makes sense. So again, if we start with wave 1, the rise in prescription opioid overdose deaths, that's what people think about when they think about like Purdue Pharma, and you've heard about like the Sackler family and sort of where the money came from and where the bad behavior, the terrible mistakes that were made by people in predatory marketing and that sort of thing around prescription painkillers. That's what we're talking about when we talk about wave 1. I'm not going to talk too much about wave 2, but then wave 3 is very much pertinent to where we are now, and you can see the giant spike, right, from 2013 to 2021 in the purple hill here. That's the use of synthetic opioids, and synthetic opioids have found their way into our drug supply around fake pills, and we're going to talk about that too. So wave 1 and wave 3 are sort of where my focuses are today. Any questions about that? Okay. So it's really important to think about all of this in relation to people. And when we talk about how many people have been affected by the opioid crisis since 2019, 250,000 people, 250,000 people have died from opioid overdose. I'm a graduate of the University of Michigan. Mm-hmm. When I think about large volumes of people, this is what I picture. This is Michigan Stadium on a football Saturday. You can seat 110,000 people in the stadium. So when I'm thinking about any kind of population health thing, this is how because it's really hard to visualize, right? When have you ever seen that many people in one place, right? 250,000 people in one place. So more than double this number of people. How many families then do we talk about when we think about how many individuals are affected? If you lose a loved one, right, that's 2, 4, 6, 8, 10 people who have lost you, right? If you have died, if someone has died, if you've lost a loved one, there's many people that are affected by that death, right? So this is more than double this number of people have died in 5 or 6 years from opioid overdose. Think about how many families we're talking about then on top of that, right, that are affected, how many individual people. So again, I'm not trying to be flip, I'm trying to give us like a picture of what we're really talking about and the human effects, the toll of this sort of kind of broad thing that a lot of us hear about a lot in the news and may or may not have personal experience with. So going back to the idea of the first wave, so in the 90s, 1990s, when prescriptions became a problem, 191 million opioid prescriptions, so prescription painkiller prescriptions, were written and dispensed to American patients in 2017. That's a huge number of painkillers, and not all of those were correctly prescribed. There's a wide variation in opioid prescription rates across the United States, and studies have suggested that when we've looked at regional variations, it's not the health consequence, the reason like a shoulder surgery, back pain, it's not the diagnosis that's dictating where those prescriptions were written. That's where the sort of through lines were written into the predatory behavior of Purdue Pharma and pharmaceutical representatives who overprescribed, pursued physicians to keep writing more prescriptions, and incorrectly provided individuals with substances that they became addicted to through no fault of their own. So the most common drugs that were involved in the opioid overdose sort of prescription side of things were methadone, oxycodone, and hydrocodone. So OxyContin and Vicodin are the things you may have heard about as sort of the brand names. There's lots of, you can read a lot about this. There's like Netflix documentaries on this now that have recently come out that really illustrate in depth sort of this first wave of the opioid crisis and what this means and really what happened. We could have like a weekend seminar on this, and we have, 45 minutes? So I'm trying to move pretty fast here and cover a lot of information, but really sort of give us the big picture. So skipping to the third wave, we're talking about fentanyl and fake pills. Okay, so moving from the idea of like you go to your doctor, you get a prescription after surgery, and then you get another prescription, and you fall into a pattern of addiction. There's moving to the concept of the third wave, there is an increase in the amount of fake pills that are available. Over 75% of the drug overdose deaths that happened in 2021 involved an opioid, and 7 out of every 10 fake pills that were brought in by the DEA contain a lethal dose of fentanyl. Many fake pills were made to look like prescription drugs, so like the ones I just talked about, right? So if you need, because you have an addiction and you don't have a choice, I will talk about what addiction is, but you are seeking more pills. If you can't get that through your doctor, you can look for them other ways. So you can find pills through a friend, a dealer, somebody who knows somebody, and what those pills look like, they're made to look like prescriptions, okay? I'm going to show you a picture in a minute. From 2019 to 2021, overdose deaths among persons aged 14 to 18 increased by 109%. So what we're talking about fake pills, is the pictures on the far side. So authentic oxycodone are the ones in blue, and then fake oxycodone are the ones in white. If you didn't know the color difference, could you tell the difference in those two pills by looking at them?
And why is it fake? Why are they called fake?
They're made in not in a like a prescription, like a pharmacy setting, or a like by a drug manufacturer. They're made in a lab in a basement in another country and brought into the United States in and around the United States using fentanyl that has come from other countries, and it doesn't there may or may not be, like, so if you think you're getting oxycodone, you may have that drug may be in that pill, but there are other things in that pill too. This is not something, we're not talking about going to the pharmacy, we're talking about knowing someone who gives you a baggie or you buy a little bottle from them. We're not talking about what you're going to get from your doctor's office or from CVS or any drugstore. But you can't tell the difference. So there's stories all the time in the news. 2 college kids pressured, feeling like they have to stay up all night to study for a final exam. Somebody they know says, I have Adderall, it's going to help keep you awake. This is not Adderall, it's come from someone's doctor's office. This is a fake pill that's been made somewhere else, and it can easily contain a tiny little bit of fentanyl, which is the fake synthetic opioid that I talked about. It does not take very much, so that much of the tip of a pencil can be a lethal dose. If you make a fake pill and you throw in a little bit of fentanyl in there, because fentanyl is highly, highly addictive, and if you're a drug supplier, you want your customers to come back and keep buying from you, so you make more pills with more potent drugs that you're not looking at a list of ingredients, right? You just know that you want more and need more, and you go back, if this amount of fentanyl can kill a person, you don't know that that's in that pill. There's no way to know with every single pill unless you test it, and if you test it, you've destroyed the pill. So we'll talk a little bit about that concept, but it does not take very much. And so what I was trying to explain with this slide is that 7 out of every 10 fake pills brought in by the FDA, or by the DEA rather, through a raid, for example, or a sting operation or whatever they're doing to find these pills with law enforcement, contains a lethal dose of fentanyl. So if you're taking fake pills, you're gambling with your life, is the point. And that's where Narcan comes in, and the idea of a rescue, something to do while we figure out how to stop the drug supply, how to help people who already have an addiction. That is where something like Narcan comes in, which is what I'm going to talk about toward the end of our conversation. So you can sort of see this is a kind of, this is not a linear thing. It's really hard to talk about this in sort of a step-by-step. We're kind of circling our way through this conversation. So make sense about the idea of a fake pill? So it's really important to remember that addiction can affect everybody. All genders, all sexual orientations, all income and education levels, all races. We can talk about parents, young adults, teenagers, and older adults. And since I'm here with you at the COA, I just wanted to highlight a couple statistics on the older adult side of things. So 2.5 million seniors struggle with addiction at any one time, and between 6 and 11% of emergency room visits are related to substance misuse are by seniors. So it's not like this is like a young person's problem. There are many co-occurring factors for anybody who has a substance use disorder. Isolation and loneliness are particularly related to substance use by older adults. So there's lots of reasons to build community, to be known by and to know your neighbors, right? To hold each other close in whatever way we can do that within our communities. And certainly isolation and loneliness and prevention of that, and then sort of the trickle that can follow in terms of choices and concerns around addiction are all just part of that picture, if that makes sense. So obviously this is a really heavy subject. And again, we all have different levels of experience with this. I'll talk about different, we all talk about, I'm sure, personal stories with this. I don't want to only be negative with this. I'm just trying to sort of set the stage or the table to understand sort of where we are. There are certainly things that can be done, and there is always hope around substance use recovery. So lots of things that we can do, including expanding harm reduction tools, and I'm going to talk about what harm reduction is in a minute. Expanding our awareness, which is what we're doing today, certainly, and access to treatment. Improving detection of overdose outbreaks. There's actually very specific like networks of first responders, ambulance calls. There's really amazing data discovery that's going on around if there's a particularly illicit and deadly, if there's a particularly deadly drug supply that's released in a city, for example, you can start watching the 911 calls and you can see the patterns. And if we can utilize our computer systems to help people, we can actually pull people in and understand and do better prevention work that's extremely specifically targeted based on particular drug supplies. So there's lots of interesting work there happening. We can also improve the way we treat pain and the way we think about it as a society and how we listen to people and how we listen to patients. I mentioned I started my career in hospice. Much of that work was around pain control. And much of the work I had to learn to do was to really hear people, right? To ask questions. I don't like the word, you heard me sort of stumble there, I don't like the word patients, I like clients. Because patients to me, which is I know what we all call ourselves in the healthcare realm, right? You go to the hospital, you're a patient. That to me sort of purports passivity. And we all need to be active members of participating in our own healthcare. So a client I like better because that's a relationship, right? We're working together to further someone's healthcare. So that's where I go with my thinking and where I go with any kind of one-on-one relationship when I'm working with somebody. And public health is a really unusual kind of nursing. I can have a one-on-one conversation about what kind of vaccination somebody needs, and then I can talk big picture about a whole community-wide program. So it's a very interesting sort of spectrum. So we can also consider how we talk about and expand our prevention education. We can support those that are living with addiction already, and certainly advocate for ongoing parity in the care of our physical and mental health, which is something we're definitely going to hear more about from the policy side of things when we think about healthcare spending in the future. Highlighted in pink on the screen is just national survey data that really talks about what are the barriers to treatment and recovery for folks who are seeking help. 37% of people report that they cannot afford to go to rehab. It's incredibly expensive, and our health insurance is not particularly robust in covering this. 8% of people do not have adequate transportation, and 7% of people fear that they may lose their job if they take time off to get treatment. There's sort of, like I mentioned, layers of all of this, right, in every aspect of our society and our lives, whether it's an employer's policy on drug use and drug testing, and if that's sort of created to allow for people to be in treatment while they're working, which is absolutely should be the case, or if we're talking about, you know, votes and policy and sort of where we put our advocacy attention as adults in any society. So there's lots that we can do and feel empowered for around making change, and certainly understanding the problems that we're talking about is helpful. So if I'm sure you all are here motivated by different things, but I'm hoping that you take away today some sort of empowerment, knowledge, and information so that you can feel like you can be a little more educated and to be sort of consumers in this process. Yes.
If you're unionized, a lot of times it's in your contract.
Yes.
That they can't fire you. You have if you voluntarily go for help.
That's true, but all contracts are written differently,
Right.
And it definitely takes a close read when those negotiations come up.
Yeah, because it might be a limited basis.
Yep. So now I'm sort of going from the big picture, the sort of stage setting, to talking about a little bit about what the opioid abatement settlement funds are. So we're just going to kind of move through the same agenda. So we're on number 2 here. And you may have heard about this at some point in the last 6-8 years. So first, Maura Healey, when she was our current governor, when she was Attorney General, was the first Attorney General to bring suit against an opioid manufacturer around unfair and deceptive sales tactics. And essentially the suit talks about how the company aggressively promoted prescription opioids including tens of thousands of in-person sales calls to Massachusetts providers, which resulted in a flood of inappropriate prescriptions. So that's that wave one I was talking about. It took, I don't know, 15, 20 years to really get to some meaningful legal work around this. It's a long time and it's really complicated. So our current Attorney General, Andrea Campbell, has sort of carried this work through into her work. And now there was even a new settlement that was announced in just this past February around marketing. So we're going, like, looking at the manufacturers, we're looking at how information was given to people, and again, that relates to how we as consumers, how aware we are and how attentive we are to the messages that come to us, right? And it's always appropriate to question sales, right? So that wave one, like we've talked about, the statewide settlements, which is very complex. It involves 8 pharmaceutical or companies or pharmacies. It is essentially is resulting in over $1 billion at the state level over 18 years that should be directed for recovery, prevention, and education. And we'll talk about exactly what those sort of areas are in a minute. 40% goes to cities and towns, 60% gets used by the state. This is like high level, right? It's very complex. The town manager here in Wayland is going to hold a special office hours coming up in a couple of weeks, and he'll talk about sort of exactly the timeline and the money that's coming in, and solicit ideas from anyone who wants to participate about what should be done with this money. But just high level, 40% is going to cities and towns. Cities and towns in Massachusetts had to sign on to get the money and agree to these terms, essentially. It's a contract. We've learned a lot from the big tobacco settlements. So if you remember, right, the idea of we've been marketed a substance that's terrible for us, right? And what is the remediation for that? That was sort of the point of the tobacco settlements. We as a society didn't do an awesome job at carrying that out, right? Some of that money was misused. It wasn't particularly accounted for. It was used for things other than remediating the harm of tobacco or prevention work. So we're trying very hard to be detailed in our sort of moving forward with these settlement funds around the opioid crisis. To that end, of course, as you would expect, right, you can read between the lines, it's very complicated to figure out how to use the money, how to get it, how to put it forward in communities. And there's a lot of really wonderful people working really hard at the state level and the local level, both at volunteers, people who are employed by like nonprofits, and then people who are employed by cities and towns to really do it right. But it's complicated. So the priorities for municipalities have been put forward by the state into these 7 areas. We have to use the money for opioid use disorder treatment, to support people in treatment and recovery, to get people connections to care. Remember I told that statistic about how hard it is for some people to get to where they need to be to get treatment. If you're in active treatment for opioid use disorder and you are out of that initial stage of withdrawal and you're trying to be home and having a job and living with your family, you can be on treatment for, which is medication-assisted treatment, for anywhere from 6 months to 8 years. And if you can't have that medication at home with you, you have to go every day to get it. So think about that roadblock, right? Like, how do you get there if you don't have a car? How do you get there if you have to take public transportation and hold a job and you live somewhere like this where there isn't a network of public transportation, for example? So that's what we mean by connections to care in some part. Harm reduction work, which we'll talk about what that is in a minute, the idea of risk reduction. The needs of criminal justice involved persons, so helping people who are have had legal action taken against them for like possession, for example, and how to help those folks move forward with their lives. Support for pregnant and parenting women in particular, and the prevention of misuse of opioids and implementing prevention education. So there's like sort of 7 buckets, right? Specific. And all of this has to be informed by people who were directly impacted or have lived experience with opioid use disorder, opioids in some way within their families or directly themselves as someone in recovery or even in active use. So the settlements, again, are complicated and they are prescriptive in that they give us a framework and we have to figure out how to function within that. Within the health department here, we've done a lot as the sort of idea of these settlements comes forward and we have to figure out how to proceed with this money and as a town and as a region and a state to use it to the advantage to help people that we've harmed, that have been harmed by this crisis. We've done a lot of work sort of as we can because this is what we do, right? And at the local level and the municipal level, we have only so many hours in a day and not that many resources, and we are creative. And so what I figured out in working with the state is there's a community naloxone program where a federal grant provides free Narcan. Narcan is a brand name of naloxone to municipalities, and we have done a lot of work around distribution of that. The schools have been marvelous partners here, and they allowed me to come into every single school and do a faculty meeting presentation where I sort of gave the second half, the sort of upcoming part of this conversation, to all of the teachers and offered them Narcan. And I have to say, like at the high school, they're like, yeah, bring it, let's go. Like, what do you got? Educate me. At the elementary school, a couple of these teachers are looking at me like, I teach kindergarten. Like, I'm not sure that there's going to be kindergartners with like a drug addiction, right? Not the point. The point is something that we learned from the pandemic. When we talk to the schools, we reach adults that live in 35 different towns, right? Some of them live right here, some of them live in a neighboring town, some of them drive 25, 40, 60 minutes to get here. So that's public health at its best, right? How do we cast a wide net, empower people through whatever way we can, however we can reach them to make a difference? So it was an incredible opportunity. Every time I got to talk with the school, always somebody came up to me afterward and said, thank you, I just feel so grateful to be able to do something. I'm so worried about my brother, sister, cousin, neighbor, friend. And now at least I know something to help that person to live another day. The other thing was the beauty of the idea of let's talk this through and then take this home and have this conversation at your own dinner table. And I actually had one of the vice principals of one of the elementary schools took the time to send me an email the morning after I met with her group to say that she talked about this with her teenage sons at the table, and then she FaceTimed her college-age son in North Carolina and talked about it with him. So like right there, I'm like, okay, that's just like, I'm getting goosebumps, right? Because again, public health at its best. How do we reach people wherever they are and whatever part of their lives they're in with information that can be empowering? So in addition to the community naloxone program, we have engaged in lots of partnerships. So certainly with the schools, also with facilities here in town, recreation, public safety, and thinking about how we can get information forward. I have upcoming community trainings that we're working to schedule at the library so that we can have this sort of second part of this conversation there for anybody who's interested in learning more about Narcan and harm reduction. We're working to get the Naloxone Narcan put in the AEDs around town so that it's just sort of one more emergency tool, right? If somebody's heart stops, you can use an AED to restart their heart. If somebody's respiration stopped because of opioids, you can use Narcan to restart their respiration. It's just one more tool that we can have available. Certainly the education piece is high, conversations like today, but anytime anybody wants to engage, I'm happy to have a conversation about it all, the big picture or something little. And we're actually contributing to research. We are enrolled in a study through the schools that's looking at how to improve the program that is required in all schools around harm reduction and substance use conversations. So there's a sort of assessment called SBIRT, which is, it's an acronym, and really what it means is sort of early screening and a brief intervention, so that and it's required of all 7th graders and 10th graders at public schools in Massachusetts. Massachusetts is the only state that requires this by law, and not only do we already have it in action and we collect this data and we do this work, we're already looking to make it better. So the study that we're enrolled in is looking at how can we improve the SBIRT tool, that assessment, beyond just the conversation with the classroom. And as a result of that, the Wayland High School was randomized to the arm where we get a fully paid 5-year wellness coach, half-time FTE, so 2 days a week, to be in the nurse's office to not only do the SBIRT screenings, but to be a resource for kids and faculty around substance use. So it's like just an awesome opportunity. And through that, we do data collection. So that sort of leads back up to the idea of partnerships, and the schools have been a wonderful partner in that. So again, not only are we trying to figure out how to get information out to people, we're trying to improve the information by collecting real scientific data in the process. As part of all of this, of course, is the idea of stigma reduction, meeting people where they are and normalizing that there are tools available for folks who are struggling with substance use disorder, and providing resources for those folks or anybody who has questions or needs to learn more. So that's we've been big to sort of medium, the state level and then the local level, what the response is in Wayland. And now we're going to go to sort of narrowing the funnel a little bit more and talking about individuals and what we can do to help one person at a time. So to do that, we need to talk a little bit about what substance use is, and sort of and we'll get into what harm reduction is. Substance use occurs on a continuum. In healthcare, we like continuums. We like spectrums. We talk about these a lot. So this is just one way to represent the concept of using substances. I could be talking about prescription drugs. I could be talking about fake pills, illicit drug supply. I could be talking about substance use as medical marijuana or recreational marijuana or alcohol, right? Those are all substances when we're talking about this. And each of us is somewhere on this with all of those substances, right? This is an individual choice, an individual place where we find ourselves or where we could be marked on the scale. And I'm just putting this forward to kind of set the stage that we can go from anywhere from no use of substances to sort of chaotic or inability to stop on one's own choice, and somewhere anywhere in between. And this is a personal spectrum. So when we talk about substance use, we talk a lot about the term harm reduction, but that really starts with the idea of risk reduction, and we reduce our risk in society all the time, right? Seatbelts and speed limits, the whole point of those is to reduce the risk of death from motor vehicle crashes. Right? I remember clearly being a kid growing up in Weston, where I live now with my own family. I have 3 teenagers. And I remember kind of rolling around in the back seat of the car, right? No seat belts, no nothing, right? Every car had a bench seat. We took long trips. Like my sister got the seat, I got the floor. Right? So we figured that out pretty quickly, which is good in the 80s. Bike helmets are now totally normal, right? My kids never get on a bike without putting on a helmet. Definitely not the case when I got on my banana seat bike with the cool streamers from the handlebars in the 80s. Vaccines are also another way we reduce risk, right? We choose to get vaccinated to reduce our risk of consequences from COVID-19, from influenza, and then from all those other polio and measles and all the other things that are part of our routine childhood vaccination plans. Face masks can reduce our risk of respiratory viruses, but also reduce the risk for others if we go out and we are ill ourselves, right? Staying home when sick, another way we reduce risk to others. Hand washing, that's just the public health beauty right there, right? We could talk about that all day. It's its own lunch and learn why we wash our hands. Condoms certainly reduce the risk of unwanted pregnancy, but also STIs. And then naloxone, Narcan, is the way we reduce the risk of harm from opioids. Food expiration dates, right, keep our gastrointestinal systems healthy, and that's a big part of what we do, the sort of food side of things in public health. And then sunscreen, right? I don't think often we think of this as harm reduction. I do now, because this is where my head goes, right? But when we're putting on sunscreen or your daily moisturizer, which by the way should contain some sunscreen, that's harm reduction risk, right? The idea of reducing your risk for exposure to the sun and reduction of risk of skin cancer. So that's lowercase h, lowercase r, harm reduction, the concept of harm reduction. Now we move into the science of harm reduction and the idea of attempting to reduce the negative drug-related outcomes. So with harm reduction, there may have the eventual goal of abstinence, but what that does is the concept, the science of harm reduction, allows for flexible treatment goals. The point is to meet people where they are. You used to have to be sober to seek treatment. That is not the case anymore. The idea is if you are sober curious, this is a concept, sort of a newer term you may have heard. If you want to know a little bit more and you're still drinking or drugging, we'll talk to you, right? We want to meet people where they are. Harm reduction, the approach is comprised of 5 principles. It is practical, it is person-centered. Remember I said we're talking about the individual here, right? Meeting people where they are. We're focusing on harm as a consequence. It is cost-benefit understanding, and that's particularly helpful when we're talking about trying to move science forward and thinking about public policy. We have to be able to pay for programs. We know that it is cheaper to help someone when they want to be helped and not wait till they're in crisis. It is immediate and it is response-driven, and it is most of all centered in, again, that concept of meeting people where they are, but not abandoning them, not leaving them there, but being present and being participatory whenever it is that they want to seek help. The goals of harm reduction are similar to all those risk reduction things we talked about, right? The idea of reducing the risk of infections, the risky drug use, preventing drug overdose deaths, providing honest drug education, and increasing contact that folks have with services, support, and treatment. So there's lots of different strategies for harm reduction in substance use, whether that's clean syringes, providing syringe disposal places. Narcan or Naloxone is, again, just one tool instead of the harm reduction continuum. You probably, if you're a newspaper reader or a news watcher or listener, you've heard about supervised consumption sites, and you will continue to hear more about those in Massachusetts. Drop-in centers and other places that provide what we often call wraparound services, right? So I talked again about going way back to that slide where I talked about what are people's barriers to treatment, right? Wraparound services may be housing, food, jobs, transportation, emotional support, anything like that, right? Help with children, childcare, lots of different sort of areas of that. So that's harm reduction. Learning all sorts of new things. Any questions about that concept? Okay. So just very briefly about addiction. Again, we could have an entire conversation about addiction alone, and we're moving away from this term in healthcare, and actually in the sort of diagnostic manual for psychiatry, which is where sort of the DSM-5, where we talk about like sort of what concepts are. We've removed the word addiction, and we now talk about substance use disorder. The reason for that is there are many types of addiction, sort of loosely grouped. There's the idea of addiction to substances, and then behavioral addictions. So we're talking here about substance uses. And it's really important to remember a couple of things, and I think this is where folks need to really understand the sort of level set here on like what this conversation is about. Substance use disorder is chronic, and it can be relapsing. So just like chronic kidney disease, right, or if you are diabetic, that's never resolved, right? you are diabetic, once you're diagnosed as a diabetic, you are on some, there's that word continuum again, right? Some scale as a diabetic, whether you are controlling that with your diet and exercise or medications or insulin, you are on scale, right? You may be having other consequences as a result, like dialysis for chronic kidney disease as a result of that health condition, right? Those are all sort of that continuum, and that is a chronic illness. A substance use disorder is no different. It is an illness. It is characterized by changes to the brain, changes the function and structure of the brain. So we're talking biological changes as a result of substance use. It is not a choice. It changes a person's biology, and it is influenced by many factors in one's life, where you're born, the family you're born into, the conditions of your life, the interactions that you have, the trauma that you face as you go forward through your life. All those things are influential on one's sort of where they fall, when one falls on the use of substances. It's important to remember that this is a treatable medical condition. So again, returning to the concept of hope and remembering the people at the center of this conversation. So, moving all the way through, now I want to talk a little about what is a drug overdose. So a drug overdose is when we have a toxic amount of drug or drugs that overwhelms the function of our bodies. Way back in the beginning, I talked about what opioids are and what they do, right? And I talked about how they work on the brain. So when you have too many opioids in your system, your breathing can slow and stop. And when the brain is deprived of oxygen, then your organs obviously don't work, right? We think about the brain as the center function of the body, moving, sort of telling everything else what to do, right? If your brain's not telling your heart to pump, your heart's not pumping, moving blood to your, oxygenated blood to your lungs, you're not breathing, right? All those things happen as a result of an opioid overdose. There are many risk factors for overdose. Following periods of abstinence, recovery, treatment, or incarceration. So right when you're removed from the ability to use substances, whether because you're in treatment for that and in recovery, or because you've physically been removed, like you're in jail, which happens for some folks but not for all. That means that when you return to the idea of, when you return to using the substances, we're talking about those biological changes in the brain reacts differently, and those substances can overwhelm sooner than they would have before. Mixing substances are risk factors for overdose, co-occurring mental and physical health concerns, history of previous overuse, and certainly using alone, which is something that we don't want folks to do. And that goes to directly what I was talking about how risky the drug supply can be, right, with that lethal dose of fentanyl. So this is just a visual of how opioids cause an overdose. Way back in the beginning, I showed you that little picture of the opioid receptors. That's what these are in the brain. And the opioid goes to those receptors when it's ingested and sits there and changes the function of the brain. So what do we do about it? You have too many opioids in your system, now what? And this is the answer. So Narcan, or Naloxone, the Naloxone is the pharmaceutical name, like acetaminophen is to Tylenol, right? So this is Narcan, is the brand name here. This is the only drug medication that will reverse an opioid overdose. It's like anti-snake venom. It's available in Massachusetts over the counter. You can go into any pharmacy and buy it as of August of last year. It costs $43 a box. We have it for free at the health department. It is free whenever the building's open, it's out. And we have it for free at the public safety building 24 hours a day. It's available for anybody who wants it. You don't have to live here. If you know someone who you think should have a box, you can take one. If you'd like to have one at your house, you can take one. And we're going to talk more about how to use it now and why it's okay to have in your house. So, again, it's the only medication that will reverse the effects of an opioid overdose. It is safe with no potential misuse with it. So if I used it right now, I have no opioids in my system, nothing will happen to me. It is just benign. Because there's no, think about that little picture of the brain, right? There's no opioids there for it to go to remove temporarily. Essentially it blocks the brain's ability to process the opioid. It is legal in Massachusetts. It's actually, somebody asked me, it's legal everywhere else in the United States too, not just here. And it should work in 1 to 3 minutes and last for 30 to 90 minutes. So if I have used fake Adderall because I've chosen to do that and it is laced with fentanyl and I overdose and someone gives me Narcan, it's only going to last, only going to revive me, and we'll talk about what that looks like, for 30 to 90 minutes. You have to call 911 because those drugs stay in your system longer, right? Think about like when you take, I'm using something benign, Tylenol again, right? It's every 4 hours, right? So same idea, the drugs that you have ingested are going to keep working in your body. This is a temporary reversal.
Is it a spray?
Yes. I have some samples here, I'll show it to you. So how it works is like this. It goes in the nose as a spray. The little green guys is just a visual. It's not green, it's clear. And it goes to those opioid receptors and blocks the opioid temporarily and allows breathing to be restored. So there are 5 steps in responding to an overdose. If you, this is kind of the part of the conversation. Like it's unlikely that you're gonna like walk down the street and find someone like slumped over on the sidewalk in Wayland. First of all, there aren't that many sidewalks, but the idea, right, is like if you're at, I don't know, you're out for a walk at the Constituent Ball Field and you find someone like, it's not likely this is going to happen on like on a park bench here in Wayland. 70% of opioid overdoses happen in private homes, anywhere, Massachusetts, anywhere in the country. So while we talk about the first responders having Narcan available, that's because they can arrive with it, right, as part of their toolkit. I don't go anywhere now without it. We'll talk this through. I take the doses out of the box, along with the coupon, and I keep them in my purse. You don't have to keep it in the box. You don't have to keep it in your car. You can keep it in your medicine cabinet. If you have young people in your life, if you have anyone in your life who uses substances, if there's anyone that you're concerned about, like that's why you should have it around. It's just like having, I don't know, like the poison control number stuck on your telephone. The idea is it's a tool to have available. So to that part of the conversation about like where are we seeing opioid overdoses, again, it's in private homes, and there's a lot that tells us a lot, right? That's an emergency that's happening behind closed doors, right? So with that automatically comes, I don't want to talk about it. It's private. It's personal, right? Don't look at me. And that's where we get into the idea of stigma reduction. That's why we talk about the conversation of normalizing harm reduction tools, making this available so that it's easy, it's free, it's accessible. And I hear wonderful conversations all the time. Your COA colleagues come out of, any residents come out of exercise classes in the large hearing room, and I hear stories. I hear people say, I picked this up, my nephew, I heard somebody say their nephew drives for Domino's, and they thought he should have that with them because who knows where he's going and what he's seeing and what's happening when he rings the doorbell. I heard somebody else talk about a personal story today, and they're not talking to me, they're talking to each other, which is marvelous, right? Sharing the conversations, sharing the trauma, the scariness, the bigness of this, but then also having tools, being empowered to do something about it. So the details are on the back of the box. I could hand you a box of Narcan if you would like one, and I could say the instructions are here and you are trained. We don't have to have a detailed conversation. People don't have to present themselves to me for detailed training. That's all that's required for the state to check the box of distributing through me to an individual. However, you might like a few more details. So I'm going to tell you a couple more things about it. The first thing to do is always try to wake the person up. We're going to go through these in detail. Then to call 911, to give naloxone, to give rescue breaths if you are comfortable, and to stay with that person until help arrives. Quite straightforward, not all that different than the concept of coming upon someone whose heart has stopped, right? You're going to try to restart their heart if you do CPR, you're going to do breathing and chest compressions, and you're going to have somebody else ideally call 911. So you're the temporary help until the professional help arrives. That's all. So to the idea of assessing a person, we're looking for checking for breathing. We're looking for if you've not been taking enough breaths, right? We've heard this a lot in the pandemic. What does it look like if you're not getting enough air? We're talking about blue lips and blue nail beds on a light-skinned person, white lips and white nail beds on a darker-skinned person. When you say, anybody had CPR training at some point in their lives? Remember, we used to say, Annie, Annie, are you all right? Right, to the mannequins. You yell that person's name. I'm going to call 911. Are you awake? Can you wake up? Right? This little diagram is the sternal rub. My teenagers would love this if this is how I woke them up. You take your knuckles and you rub it on your sternum. Super uncomfortable. Doing that can help rouse somebody who is not awake. If they wake up, you can talk about what to do next, but you're not necessarily going to give Narcan. So you're trying to arouse that person. The next thing to do is call 911. Ideally, you're giving Narcan, opening the box. You have 911 on speaker on your cell phone or on your house phone at the same time, or someone else is calling 911. So these sort of steps 2 and 3 can happen at the same time. You would provide information. There's a person at this address that's unresponsive and not breathing. Ideally, someone is sent outside to meet the ambulance so they know exactly where to come to get help as soon as possible to your loved one. It is really important to remember the Good Samaritan law in Massachusetts. This protects people who overdose or who seek help for someone else from being charged with possession or prosecution. So this comes up all the time. We have conversations with teenagers, for example, right? They're much more likely to, if you have teenagers, a group of kids drinking too much, somebody passes out, right? Often the instinct is to run away. Never what you want to do, right? You don't want to leave that person, leave no man behind. So this idea of this Good Samaritan law, and the school resource officer talks about this a lot, is that if you call for help, we're going to help you. We're going to talk about how to get you in the prevention arm and how to talk about what substances were in use and how to help you as a person, but we're not going to haul you in and bring you to the police station and all that stuff. So protects individuals who are acting in good faith to step in to render first aid. So the Narcan itself is very straightforward to administer. Peel, place, press is all it is. In this box are these 2 little blister packs, like I showed you before, out of my own handbag. It's clunky to carry around in the box. You can leave it in the box, it's fine. But this is easily accessible also. You peel the cellophane off the back of the box, you put the little plunger in the nose, and you press the plunger. So I have some samples here. These are blanks. It says right on here that they're training devices. There's a little spring in here, so I'll drop these off and you can look at them. The idea is you put it in the nose, you push it, and that's it. It's a single dose. You can't do it wrong unless you put it in the ear. If they get stuck, the little pink thing just pulls back out again. So very straightforward to administer. Nothing that you can do that's wrong with it. Again, the school resource officer, we did a training at the same time. He was talking about school safety. I was talking about Narcan to the teachers. And I asked him if he had anything to add, and his only point was, like, if you're not sure, if you come upon someone who has low respiratory rate and you know they have a history of substance use, just give the Narcan. It's not going to hurt them. If it works, that's great. If not, either way, you're going to call 911, and you've started the process of helping that person. So it's the emergency response. So if you are comfortable, you could administer rescue breaths. It is usually necessary because Narcan does so quickly. Opioids does decrease respiratory rate very quickly. you have to always consider your personal safety when you're responding to any kind of emergency situation. If you're with a family member, that's much more likely that you're going to be comfortable with that, right? You're sharing a household with them, so that may be something that you're comfortable with. If you're in a public place, that may not be. Often in public places, there are face shields for breathing through, along with Narcan. You always want to stay with the person and ideally put them in the recovery position, something you probably also learned in your time with, at some point, with CPR and training, if you've had it. Turn the person on their side, place their hand under their chin, bend their knee, and stay with them. Couple things to remember, considerations for all this. During COVID-19 and after, essentially the protocols didn't change because opioids stop breathing regardless of whether or not we're in a respiratory pandemic. So if you're comfortable with the ideas, you would continue to provide rescue breaths. If it's a family member and you feel comfortable, you should perform rescue breathing. If you're not comfortable, again, your safety is paramount. You can't help the person that you're working with, you're there with, your family member, your loved one, right, if there's something happening to you too. So that speaks to that, the idea of empowerment again. A couple really important things to remember. If the person doesn't respond within 2 to 3 minutes, that's why there's a second dose in the box. So often people ask me that, why are there two? That's why. Often people don't wait long enough from the first one to the second one. 3 minutes seems like an eternity when you have a loved one on the floor who's not breathing, right, or barely breathing. So if you could look at the clock, if you have the presence of mind, please do. If not, it's okay. If you're not sure if it's been 30 seconds or 90 seconds, you could just give the second dose. It's not going to hurt them. It's just that it's the process of the concept. Narcan, again, does wear off in 30 to 90 minutes. The opioids will last longer, could last longer in someone's system, and they could essentially overdose from the drugs that are already in their system. So that's why you would call 911. We know we don't hear from everyone who uses Narcan to reverse an opioid overdose. It is what it is. We're providing tools and information to people. When you revive someone with Narcan or Naloxone, they're not psyched. They don't wake up like, oh, thanks. That was awesome. I really appreciate that. Like, let's talk about my substance use, right? Like, this is not the scenario. We're not talking a Disney movie here. They could have withdrawal symptoms immediately. There could be vomiting, diarrhea, body aches, sweats, anger, physical frustration, physical anger, right? You need to make sure you keep yourself safe. I'm not saying that, like, there's a spectrum, right? And the idea is to be prepared. And to keep yourself safe and to keep your loved ones safe. Narcan should be stored in a cool, dry place. People often ask me, and it's interesting, I always think it's interesting, they want to store it in their glove compartments. I'm not sure why, because we know that a lot of opioid overdoses are not happening in cars. They're happening in personal homes. So ideally, just stick it in your medicine cabinet. If you take a box today or any other day, you want to think about it, come by and pick one up at the health department or the public safety building. If you want to take one home today or two home today, that's fine. Go ahead and do that. If you stick it in your medicine cabinet and you don't think about it, and 5 years from now you look in there and you think like, oh, whoops, I need to get another one of these, go ahead and do that. It's good for, these are dated till 2026. Expired Narcan is better than no Narcan. Right, so I stick it in my handbag. I've given it to my college-age daughter. She's 20. She goes to school in New Jersey. She's got it in her dresser. She told her roommates where it is. If she moves that to her next apartment next year and then her apartment after that and it expires, that expired Narcan is better to use in a rescue than no Narcan. Expired Narcan is not going to hurt anybody either. It may be just slightly less effective. Personal story. To talk about how real this is and how pervasive the opioid crisis is. So my daughter, like I said, is 20. She's a junior in college. I sent her back to campus with a box of Narcan, and she talked with her roommates about it in September. They asked her about it. Her one of two roommates has experimented with substance use, mostly in relation to a relationship she was in with a young man. He did not attend the same college, so they didn't see each other every day. This is in October, so just about 6 weeks into the new college year this year, this young woman says to my daughter, "I cannot reach Brian. He's not answering the phone. He lives 45 minutes away." No response. No response that night, no response to text or phone calls. She finally calls his parents the next morning. Brian has died from an opioid overdose in his house alone, 45 minutes away from his girlfriend. So now this young woman has lost like the first love of her life. She is trying to cope with that grief, trying to be an independent college student post-pandemic, trying to figure out how to move forward and seek help for herself as she tries to move away from her own substance use. And that goes to that, like, sort of who's related, who's connected, right? Now my daughter has a grieving friend, right, with a substance use problem and a concern and a safety concern for her, right? Just think about those, and this is just like regular everyday stuff, right? And most people you know, if you don't have a story like this, my guess is you have a family member, a friend who has a story like this, who may or may not be talking with you about it. So we are all carrying a lot, and I may be speaking to you all, and you may have personal experience with this. So we're on a continuum, a spectrum here, and all of that is okay, and all of that should be met with the same amount of compassion and kindness. So the whole point of this conversation today, again, is to normalize these concepts, to empower you with a little bit of information, and to think about how you are the first person that can make a difference for yourself or for someone that you love. These resources are up on the health department website. The QR code, everybody comfortable with QR codes? Pull up your camera on your phone. You hover the camera over this little QR code that you're going to see everywhere now. They're all over the place. And you click it. It's going to bring you to a website. It's just a speedy way to get you to a website. So that QR code is the same as this one. It'll get you to the resources on the health department website, which are all of these. Everything from resources for individuals who are concerned about their own substance use and their own safety, to family members who are trying to support their loved ones with substance use disorder. Anything that shows in purple on here is a hyperlink. Same thing on our website. You can click through and go right to those websites. Certainly having and carrying Narcan or Naloxone, keeping it in your house or your pocketbook, backpack, if you want, your glove compartment, your desk drawer, is a good thing to do. And certainly have this conversation with your family members. So if you could all help me with the public health idea, take this conversation home, have this conversation over the dinner table or over coffee with a friend, and talk about what you learned today, and maybe talk about what you don't understand, and seek answers to those questions, which I totally get. I'm happy to answer whatever you have now or later. That would be really wonderful, and I really appreciate your time. I just want to make sure that you know, too, that we're continuing the conversation in Wayland. So we are thrilled that we're able to use some school health grant money to bring in a speaker named Chris Herron. He is from Fall River. You may know of him. He played high school, then college, and then professional basketball, and used substances throughout that whole rising time in his life. So sort of reached the sort of professional sports pinnacle, and lost it all to drug use, and now has dedicated his life to having raw and open conversations with anyone who wants to listen about substance use, about the road to recovery, about the hope that exists, and about the importance of meeting anybody where they are. The concept, again, of and those harm reduction ideas of sort of helping anybody whenever they're interested in health. So Chris Herron is coming to the high school to have a conversation just with all the students during the day on April 9th, and then we're having an event at night at 7 o'clock at the high school theater that's open to the entire community. So we'd love to see you there, and you can bring your family members if you like, and we'll provide more resources and more empowering information. Thank you.
Thank you.
Thank you very much, Michele. This was just such an important and educating I learned so much, so it was just excellent. So thank you so much for being here today. Does anybody have any questions for Michele?
Well, I was going to ask if they had people talking in the schools, and apparently he's it.
Yeah, I mean, it's definitely a layered process. So in Wayland, we're really fortunate to have a youth and family services department. Not all municipalities have this. So we have a team of folks who are skilled in substance use and sort of providing counseling and information, and also mental health supports to families. And lots of education, so curriculums in wellness now. We don't call it, like, gym teachers aren't gym teachers anymore, they're wellness teachers. And they cover the whole spectrum, the idea of empowering kids. Wellness education actually, also through grant funding that we were able to help with from the health department side of things, now starts as early as 3rd grade in Wayland. So the idea of talking about nutrition, talking about how your body works, right? If you understand it, maybe then it matters how you feed it, right? How you sleep, how you put your phone down, how you don't look at screens too much, right? How do you think about relationships when you get into middle school and early high school? How do you have a healthy relationship with another person? How do you know your value and know when someone's not treating you right and when you need to seek help, right? All those things are part of wellness now. It's pretty awesome, the kind of things that we empower kids with. And I'm hoping that the adults could have listened in and pay attention to that too. So there are a lot of resources for the young people. Frankly, I feel like we don't talk about all of those things enough for the rest of us, right? When we're not talking about our relationships with children, but ourselves as adults, whether we're 35 or 95. So that's where public health comes in, hopefully, and we're trying to, give you all tools across the spectrum of your age and wherever you are to be well.
Right. And when you were talking about the pills for like kindergartners, well, they might have older siblings or parents that use something.
You're right, absolutely. Yeah.
Where did Narcan actually come from? I mean, did somebody create it in the lab?
Yep, it was created as an antidote to opioids. For a long time, it was only available, like one of the slides you saw a picture, it had a picture of Narcan, and it was like a little vial and a needle. It used to be carried only by like EMTs and available in emergency rooms, and it was injectable, intramuscular injections. You have to draw it up, like open up a vial like we do a flu shot, draw it up and put it in a muscle with a needle. So the idea of a nasal spray is awesome because it's a tool that is available to anybody. Science is cool. Any other questions I can answer? Thanks so much, everybody.
Thank you.
All right, so